This is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm talking today with Dr. Ken Coburn, who is CEO and Medical Director of Health Quality Partners in Doylestown, Pennsylvania. Ken, thanks so much for joining with us today.
My pleasure. Great to be here, Larry.
So let's start with a little bit of background. Tell me about you, how you came to be, how did you come to be a physician?
Well, grew up on Long Island, and I thought I was going to be a naval architect, and was really into ships and boats, and worked in summers on the boat yards. And I was doing my undergraduate work, having shifted from naval architecture to international relations. This was in my youthful aspirations to do all kinds of things. And in the midst of my undergraduate work, I had the opportunity to do some shadowing of a model UN in New York, and realized that a diplomat's life, a good day for them was when nothing happened. And that wasn't exactly motivating for me. So I'm down on the boatyard doing some rigging in my summer job down at the dock, and one of the local docks asked me how it was going, and I said, yeah, I don't know what I want to do. I thought I was going to do naval architecture, then international relations, and now I don't. Now I'm lost. And he said, well, do you like science? And I said, yeah. He says, do you like people? I said, yeah. He said, well, have you ever thought of medicine? I said to him, and this was a friend of mine. I worked on his boat, even though I was much younger. I said, come on, medicine, all you guys are interested in money. I'm not doing that. And he said, oh, really? He said, well, I'll tell you what, if you come and shadow me for a couple of weeks this summer, but you have to keep my hours and be with me the whole time, then you can make your decision. And I said, oh, okay, sure. So I had this incredible opportunity, just came, serendipitously out of the blue from this conversation, to shadow a guy who became really a role model, super dedicated to his patients, obviously not doing it, primarily for the money, and great interaction and engagement with the patients and families and staff at his office. He was an internist. And I said, maybe this is a pretty rewarding thing to be doing, and a pretty fulfilling way to serve people and to have a purpose in life. And so I went back mid-undergrad and switched to pre-med, and that was the track from there.
Where did you go to medical school?
So I went to Columbia University College of Physicians and Surgeons in New York.
Then to residency?
Then I did my residency there at Presbyterian Hospital in New York City, and from there, as a third-year clerk, it was the early 1980s, and the first cases of AIDS were being admitted to the hospital. We didn't know what it was. It was called GRID back in the day, gay-related immunodeficiency syndrome, and it was just a stunning, presentation, untreated first cases of AIDS. That was just, humbling in every way you can imagine, in terms of the suffering and the toll on the patients and families, the shock and dismay and the fear in the community, and so on and so forth. And our, sort of the humility in realizing that we didn't understand it, didn't know how to put the pieces together early on in that phase of the epidemic. And that's really got me interested. And so from internal medicine training and residency, I decided to go into infectious disease, went to Montefiore Einstein program in New York City. And from that path, it took me into the HIV/AIDS clinical care track. I became the head of the outpatient clinic for AIDS at Jacobi Hospital, and then the head of the AIDS Center at Montefiore for a number of years.
And tell me now how you came to Health Partners.
Well, so from there, from after having done a fair number of years doing HIV/AIDS clinical work, I had an opportunity from New York State Department of Health, the AIDS Institute division, to look at the relative impacts of their model of designated AIDS centers, which was quite a progressive, forward-thinking approach to enlisting the otherwise very reluctant academic health centers into the AIDS epidemic. Most centers were trying to take, sort of stay with a little bit withdrawn and not be associated with, AIDS specialty services to try to keep non-HIV AIDS patients coming to their facilities. And in order to woo them in, since the epidemic was overwhelming, we needed everybody in the mix. The state of New York came up with an enhanced Medicaid reimbursement system that went along with a designation as a state designated AIDS center. And in order to qualify, the enhancements, the reimbursements were quite substantial in terms of the financial incentive. But in order to qualify, each center had to agree to put certain infrastructural components in place in their AIDS centers and have these kind of certified by the state to make sure they really were in place. And it included a framework for HIV tester counselors in the community, health educators, nurses, social workers, NPs, physicians working together in a multidisciplinary framework. And the interesting thing about that was that each site had similar staffing, each site was serving similar populations, each site was getting the same funding. But when the New York State Department of Health commissioned us to look at how each of the sites were doing as they were preparing to think about mainstreaming this into managed Medicaid, it turns out that the performance and outcomes across the different AIDS centers varied quite a bit. And the epiphany for me was that that seemed to be related to, even though all of this infrastructure was prescribed and funding was prescribed and populations were similar, the way those teams organized themselves and the extent to which they thoughtfully designed systems as a team to deliver care to patients and how they built those, because that was not prescribed by the state. And that seemed to have a very big impact on the clinical outcomes, on the costs of care. And that's what got me super interested in saying, well, wow, maybe there's more to this system design in terms of care delivery models than we realized, at least at that stage in my career. And that's what really led me to then pursue future positions that were more focused on that. So from the AIDS Center, I went to being the director of quality at a Medicaid HMO in Philadelphia that was focusing on some of these issues, that was co-owned by the academic health centers in Philly. And from there, a series of stepping stones that wound up having us start our own nonprofit as Health Quality Partners to try to continue to focus as a core mission on this issue of how to design and test other delivery models that could produce better outcomes by leveraging preventive interventions for vulnerable populations.
Now, as I recall, Ken, you were part of a demonstration project with, I believe it was 12 or 13 other that were funded through one of the federal grant. Can you talk about that project and the outcomes of that?
Yeah, that was a huge milestone for the work we've been doing, Larry. So that was originally passed by Congress in the Balanced Budget Act of 1997, I think it was, and it finally got teed up by CMS as a federal demonstration project around 2000. And it got actually implemented and launched in 2002, April 2002. And basically what it was 15 sites around the country were competitively selected based on criteria that we, for that time period, was considered, best practice around care coordination and disease management strategies. And based on that competitive application, 15 sites were invited by CMS to propose a system of targeting vulnerable populations, chronically ill Medicare beneficiaries, and a model of intervention for those beneficiaries. And each site had its own randomized controlled trial. So there was literally, I mean, this isn't the way any of these are done today, but there were literally 15 different randomized controlled trials for each of these sites going on to see if something worked, if the target goal for CMS was either better outcomes at no increase in cost, or no difference in outcomes at lower cost, or ideally better outcomes and lower cost for these interventions. So it was 15 different model designs of care management, care coordination in vulnerable Medicare beneficiaries around the country.
And as I recall, again, when you presented at our Innovators Network, your project was exceptional in its performance. Could you comment on that?
Yeah, well, so, I have to say that the other 15 sites were or the other 14 sites were very eclectic. They ranged from for-profit disease management companies to large academic centers to VN services and sort of everything in between. And they also had very dedicated, smart people. They also had really great nursing staff and other staff that were out there implementing their model in the field. And yet, at the 6-year and 8-year point, our program was the only one that was break even or net savings after program fees, plus having substantial impacts on health outcomes, including all-cause mortality and hospital admissions. And it's very interesting because when we compared as a group, there was a consortium of us from these different sites that got together to ask, well, like, what's the difference, in terms of why our program was having some of these outcomes. And, there's a few takeaways that probably don't capture the whole essence of it, but in a nutshell, it has to do with the what I'll call the discipline of the design of the program and its implementation, and the robustness of offerings, the variety of offerings to identify and meet otherwise under-addressed risks to health that this population was experiencing in a way that was a little more comprehensive and reliable and longitudinal. And those are kind of the underpinnings of what we've learned over the years, is really makes these programs more effective.
Why don't you describe your program? How does it work?
Yeah, so we call it Advanced Preventive Care. It works in very close collaboration with primary care. And, in fact, when we published some paper on the positive impacts of all-cause mortality in Public Library of Science Medicine, one of the reviewers wrote to us and said, well, this is so terrific. Do you think it would work in other countries, that have less resources and maybe don't have as well developed a primary care system, such as, sub-Saharan Africa and other places in the world? And I wrote back in response, I said, well, number one, we really don't know because we haven't tested it in that context. But number two, it's so dependent on the connection with the primary care providers that, I had doubts that you could just take this in isolation and just plunk it down somewhere without a primary care system. Because although the nurses are trained to really look for those other risk factors that maybe the primary care team doesn't always have time or visibility on, that might be present in the home environment, anything from the physical hazards of the home to the social hazards in the home, including abuse and neglect from family members and others, to behavioral traits that maybe one would pick up by looking in the home environment, to resource needs, including what's in the pantry, et cetera, et cetera. The fullest set of those kinds of risk factors is what, our nurse-led model really is, in a very disciplined way, attuned to assess and then identify and then address. Even though those are all complementary in some ways to what primary care is also trying to do, there's also a big clinical component that does rely on connecting directly with the primary care team and making sure that whether it's medication adherence, clarifying confusing medications, simplifying meds, monitoring for symptoms, monitoring for functional declines and cognitive declines, et cetera, all of those, when you think about the full spectrum of how full-featured, well-trained people as additional eyes and ears and brains in the ground close to the lived lives of these folks can offer the primary care providers, when those are really working in synchrony, that's where we see the biggest impact. That's where we see the 34% decrease in all-cause mortality at 2 years in a randomized trial, highly statistically significant, 3,000 randomized individuals. And when we see even at a 5-year duration post-enrollment, a still significant 22% decrease in all-cause mortality. That's a big, hard outcome in a randomized trial done just as rigorously as you would in a drug trial. And it's because we're opening up the total spectrum of risk that these patients face. We're fast tracking those that the primary care team can respond to. And for the rest that the primary care doesn't have easy answers to address, whether it's housing or abuse and neglect, we activate the other community agencies that are needed to address those as best we can. So we have an ethos that we're accountable for every possible risk that we can identify, even though that's a ridiculous sort of framing, since we have nowhere near the resources or capabilities to address all those risks. But the point is, someone should take accountability, even if it's an issue of a housing problem or an economic problem or a social risk, and do what they can to activate the resources available to help address that. And that's, I think, a fundamental missing part of our health system broadly. And although I'm always inspired by the examples you give, where more and more primary care providers are stepping up to try to assume that accountability and find ways to do that, it's a challenge that we're all facing, and we don't have an adequate solution to that yet. But I think this starts to point in the direction of how great the results and how big the return can be if we were to commit more to that.
Give me a thumbnail description of your basic, how does this program work? I know you have teams of nurses that report to you, but kind of lay that out for us.
Yeah, so essentially, specially trained RNs are the key workforce element in the model at this point. And that's not to say by any means that we don't see value in lots of other disciplines being a part of this. It's just that we haven't had the resources to build and design all of that in yet the way we would like to. That's future R&D work we really, really hope to get to, because as proud as we are of the results we've seen so far, it's clearly not nearly even as impactful as we could be. And so we've sometimes had guest pharmacists, PharmD folks. We know the value of physical therapy, the huge value of social work and behavioral therapists involved in some of these circumstances. So I think what I'm describing to you, Larry, is just the bare minimum of how impactful this could be if we could continue to bring those other disciplines and capabilities together. But what we have today is we train nurses who have significant experience in the outpatient setting, typically visiting nurse or hospice-based, but we do have nurses that come from acute care settings, including the ED, CCU, and step-down ICU units, who are tooled to be able to go into the home and in a very disciplined way. The first 2 or 3 visits is a comprehensive initial assessment that's a biopsychosocial environmental assessment that is a compilation of a lot of evidence-based tools for doing this. We try to take evidence-based tools from any and every place we can to integrate into this model. So much of what really makes this work has been great work that others have done, that we've just said, hey, that looks like a really powerful way to evaluate overall status. So we blend those together, and in 2 or 3 visits, we have a pretty comprehensive sense of what are all these risk factors. And again, when you look at that in its broadest sense, these more vulnerable older adults, whether they're living alone or whether they have a caregiver or a network available to them, have usually many dimensions, multiple simultaneous dimensions of risks and vulnerabilities across the spectrum with that initial intake. And then on a personalized basis, working with the patient, working with the primary care doc, we start to help prioritize which things to go after. Which ones are they ready to address? Which ones aren't they ready to address? Which ones does the primary care doc feel is an imperative to work on now, and which can wait? We don't lose track of the full list. We're very patient in sticking with, eventually getting to all of these, but you can't do everything at once. And patient engagement and their acceptance level of what they're ready for and what the primary care provider thinks is a priority is the key to starting to lay out those first set of areas of work. And then for those, we have a portfolio of interventions, again, evidence-based interventions that other smart folks have worked on. So whether it's gait and balance training to prevent falls, whether it's, we have a very disciplined med reconciliation process that is about a 6-page long how-to. It's very disciplined. It's not about, have you had any change in your meds? And people say no, but, it doesn't really reflect the reality. And so on and so forth, weight management, self-coaching for monitoring home blood pressures, finger stick sugars, lots of nutritional counseling, lots of activating their network, activating their family, and helping their family feel more confident about understanding how the pill box should be managed, what to look out for in their loved one as a change in status, and when to call for help. Action plans on the refrigerators. It's a whole set of ways of supporting people to know when and how they can seek help for things that they should in a proactive way before they wind up feeling so short of breath they're in the emergency room.
So the nurse goes out in over 2 or 3 visits, makes an assessment, brings together the data. What does he or she do with that when they come back to your team?
Yeah, so mostly there's a system if things are really complicated and especially challenging, or we have to get area on agency or adult protective services involved. Sometimes they'll present their case to a senior clinical lead, which is a senior nurse who's got a lot of experience working those systems issues, but primarily they'll be working on an as-needed basis to communicate identified issues and clarifications and medication changes or accelerating follow-ups with the primary care doc and the practice. Occasionally, every week we select cases to present as a group to the team to problem solve together. And we sometimes have outside guests like PharmDs and others who are interested in this approach to care come in and discuss those cases. But the other key thing, which I think you're pointing to also, is the longitudinal, steady, ongoing, consistent engagement and connection with patients that this takes. This is not an overnight, quick evaluation, go in, put an action plan in, hand it to the patient and think that that's done. Or even what we've learned is making multiple referrals to different resources. Things don't happen the way you hope they will. That resource doesn't get back to the patient, or they get back, but the patient was confused and said, I don't know who you are, I'm not going to see you. And these iterative loop closures and reinforcement and support of the patients and families to be able to fully harness the resources that we try to bring to bear to help them over a longitudinal time period is what I think really has made the biggest difference.
In terms of, well, let me first ask, how do patients come to you?
So we've had a variety of ways over the years. Our program is really the way we've survived over now coming on to 20 years doing this is through basically early adopters that see the value of the extra effort and resource investment and time that you need to invest in this. You have to be constant to this purpose for a while to see the impacts and the results, which as on a population base probably start to hit 18 to 24 months after you start a program. So if you're in an ACO or you're in some other kind of value-based contracting and you turn this on, the first 6 months, you're not going to see a return. The first 9 months, probably not. Maybe at 12, but certainly by 18 months, you're going to start to see a net benefit and savings that's going to help fuel the success of that program. And we've seen that in a number of contexts. So some of the folks that contract with us to provide this are provider systems that have bundle payment programs under CMS, for example, for heart failure. Some of the folks have had value-based contracts through Medicare shared savings programs, so CMS as an ACO, or through private health plans in their area through various value-based contracts where they have an opportunity to get a return on the net savings, which also comes along with this program. I'm highlighting the big clinical outcomes because in some ways that's what motivates us. That's why and how we built it. But it actually turns out it's much less expensive, even net of the program costs. So in the CMS randomized trial for higher risk folks, there was a 39% decrease in hospital admissions, 37% decrease in ER visits. There was a net savings of just shy of $400 per person per month. Again, targeting the higher and rising risk Medicare population and implementing this kind of model with a lot of fidelity and reliability is how one can achieve those kinds of impacts. So we've been contracted by health plans, provider systems in value-based contracts. We've been asked to serve as a resource to help others implement the model. So a payvider, a family practice-led network of care up in Maine that also has a Medicare Advantage health plan of now 50,000 lives, asked us to teach them how to do this. And they've implemented very successfully. They're in their going on their 5th year of implementing it up there. There was a secondary health plan in Tasmania, Australia that asked us, that did an evidence-based review and found us, came over, visited us, went out in the field with the nurses, looked at our management system and our IT support system that helps support all of this work and train the nurses. And they flew me over there and had me go around to make sure I thought it could work over there. And they've adopted it and been very happy and successful with it in the last 4 years. So we have these little areas of early adopters that are very progressively thinking about making this kind of an investment. And it's again, a testimony to the importance of how this should be working with primary care. The folks up in Maine are a very, primary care led system with a health plan that sees how this could extend their capability as a primary care provider.
Yeah, one of the things that was most striking to me, both when you presented at our Innovators Network, as well as when I read the article that was it the Washington Post, or that, I mean, that was just very striking. The thing that really spoke out the loudest was elders are living longer and still costing less per person than with traditional care. I mean, that's just so counterintuitive, but remarkable that people are getting to live longer. And I would guess that their functional capacity while they're living longer is better than it would have been had they been untreated.
Well, I think that's true, Larry. I mean, there were a few things in that randomized trial that we would have loved to have had more data points on in the control group. That functional status question is one, but I'm pretty confident we would have seen that bear out in the data. It certainly seems to be true when we observe the experience of patients in the program. And the other thing I'll say is that, despite the great impacts on all-cause mortality, and I believe, as you're pointing out, functional status as well, it's all through these preventive efforts. It's not because we're, trying one more heroic cycle of chemo at the end of life. And in fact, quite the opposite. The one area of significant increased expenditure in our program is in the area of hospice. So when it is end-of-life planning, there is a lot of advanced care planning that is part of the program. And we certainly don't, push hospice. We don't, we're not a purveyor of hospice. We don't get any financial remuneration for referring to hospice. But once you have had a chance to build a relationship with people and understand their personal goal-directed values and for their own life, and they have a trusting relationship with a nurse who's been committed to helping them extend that life as well as they possibly can through these preventive efforts. But it becomes time to plan for, the terminal phase. Patients couldn't be more grateful for our help in helping them advocate what they want at the end of life, which the system, it doesn't always make it easy for people to get in accordance with their own wishes. So in the randomized controlled trial, hospice expenses were actually doubled in our cohort compared to the usual care control group.
That's one of those positive outcomes. Everybody's trying to figure out how to help particularly frail elders at the end of life access hospice to get the right kind of care so that they can have a good death. And it sounds like you're on to one of the ways to do that.
Yeah, no, I don't think there's any doubt on that front. And that was, as I said, data points that were collected in the randomized trials. So I'm pretty confident on that one.
Very cool. So where do you see this all going?
Well, that's a great question. The challenge of scaling this has been one of the most formidable new challenges we're facing. And we thankfully, we're getting some help. We're getting some foundation support to look at this question of scaling. And it's a fascinating one because nowhere that we go do people sort of second guess the quality of the evidence in terms of these longitudinal randomized trials, and other data. We have other data points as well in other programs that are not randomized trials, but are strong propensity score matching or weighting outcomes analysis. So nobody's really doubting that this can produce these results, except that there seems to be something that almost, and this could be a divergent conversation, Larry, so I'll let you manage me on this. What I'm calling the Semmelweis dilemma, sort of based on Ignaz Semmelweis's experience with discovering that hand washing and cleansing saved lives in a birthing center, before there was germ theory available. There seems to be something that, there's a theory, a practice, and then an adoption and a scale. And ordinarily, when you produce a practice that people have a theory behind that they cognitively and emotionally understand and feel comfortable with, and it makes sense to them. And then you show them data that says, hey, look, that thing that you cognitively understood and felt comfortable with, it really is true. And here's the data. Then adoption is not easy, but it's easier.
Right.
When you present something that just somehow doesn't feel to people like they have a cognitive schema and an emotional framework to readily accept in the way they believe the world works, even if you show them the data, that's
right.
Absolutely, unequivocal. They have a hard time fully getting behind, accepting it and adopting it and championing it. And I think that's a little bit where we are, just like when Semmelweis discovered that the nurse midwives who cleansed their hands between births had a lower rate of puerperal fever, and the moms and babies weren't dying at the same rate as on the physician ward where the docs didn't wash their hands, or where they came from autopsies to deliveries without washing their hands. The data was irrefutable. I mean, it was, if you've ever seen the actual data he collected and graphed, it was stunning. Everybody would accept that this is significantly better than this, right? But there was no germ theory. And there was a cultural, perception of the role of the physician versus the nurse midwife. And there was all this other stuff, but there was no ready acceptance that the world might actually work in such a way that this evidence was showing something true. And so it wasn't accepted. And, his personal story was he was eventually drummed out of the medical profession in disrepute, and winds up in an insane asylum and beaten to death by a guard. That was Ignaz Semmelweis's. And the guy who recognized that nurses doing something they weren't sure had a scientific basis, but seemed to them to be good practice for their patients, and the data was incontrovertible, couldn't convince. The mental model wasn't ready. There was no germ theory. There was no acceptance. I feel, I don't want to over dramatize this, but I feel a little bit like advanced preventive care is a little bit like that. Yes, we're starting to get an appreciation of the social determinants of health, that there are other risks involved in what keeps us healthy or what makes us sick. But the magnitude of it, I don't think we totally appreciate. I don't think we have a germ theory yet of what that looks like. But we have very strong feelings, and many of them are well-deserved for the power of our scientific medical interventions and so on. And, that it doesn't need to be in refutation of the things we know do work for medical care. But I still don't think we have this full enough framework of what keeps us human beings in the modern age well or ill. And as a result, models like this that cut to having found ways to get to that and show these impressive outcomes are still a little hard for people to assimilate and get. I feel that's part of what's at play here.
So if I can offer a comment.
Sure.
I think in our culture, and I'm speaking specifically about the United States, we don't get the power of community. We really don't get the power of relationships. And there's beginning to be an understanding. I just saw the other day a YouTube TED Talk by David Brooks, the columnist.
Yeah.
And he was talking about the change in culture that he experienced. And he's talking about the need for community, the need for relationships. He calls them weavers, people who weave together people and ideas to create community. And I think in our world of, we're so economically driven and driven by the trickle-down theory, we don't get the value of the workforce. We don't get the value of all the stakeholders. I believe there's beginning to be a belief about the value and influence of that. So I think that's the missing piece, because what you're providing is you're the connector that's got the primary care doc, got the patients, got the family community resources through that nurse who's coming in as a friend and clinical advocate for the person. Building that community is really the secret sauce of what you're doing, so people aren't alone and detached.
I think that's a really great observation. Thank you for sharing that, Larry, because another sort of set of data points related to that is our friends at the University of Pennsylvania, the New Cortland Center for Transitions in Health, led by Dr. Mary Naylor, who used to be on our board. They did some collaborative research with us on our program about what drives the high level of consistent engagement we have with patients. We have very little voluntary dropout once people are oriented to the program. And they did, together we did with them a quantitative study of the timing of contacts, the nature of the contacts, frequency, and so on. And then we did a qualitative study, which they did through focus groups of the patients in the program. And to your point, the three main takeaways from the focus group was the first most compelling thing people said is, I am so connected and committed to this program because I now feel I have, and this was the title of the paper, someone in my corner. There was someone there who cares about me, is connected to and understands me, and is there for me in a way that is a little bit unique for our health system. So someone in my corner. The number two thing they said was they felt it was great because they're learning, that they're growing. And these are older folks and all that. They're learning about their health, their bodies. They're learning together when we had group programs and people would come together and share as peers their experiences about all kinds of things in life, not just, what meds they're on, but, how their grandkids are doing, how they're coping with their grandchildren's dilemmas and so on and so forth. And so there was learning through a shared exchange. And the third thing they cited as to why they stayed in the program was they said, my nurse is so committed to me. How could I drop out? How could I not be as committed in return? It was this like reciprocal, like social obligation that once somebody expresses a certain level of commitment to you, and we, we hear this from our colleagues at the Camden Coalition too, about especially substance abuse and addiction, that many folks in that, in that moment in their lives, if it hadn't been for somebody that came up to them and said, I believe in you and that you can get clean and you can do this, testimony after testimony said, I would have never turned that corner. So there is something incredibly powerful that you say, Larry, about the human connection, the community of support, that we just really don't yet have a full enough appreciation for how to leverage and how to put into place.
So Ken, this has been a fascinating conversation, and I'm so thankful that you agreed to be interviewed today. And I'm hoping that you'll come back to our Innovators Network, which is going to be in Pittsburgh on October 8th, so that you can share with folks your progress. I think, quite honestly, I believe every health system in America, whether an ACO or a large health system, should be contracting with you, and they should be figuring out, they're all doing some parts of what you're doing, but they're not doing the whole thing, at least not the ones that I'm aware of. And I think the whole thing gets to those three outcomes that are the real secret sauce of how you get to the, longer life, lower cost, reduced mortality and morbidity. And I just want to commend you for the great work that you're doing.
Thank you, Larry. Much appreciated. And thank you for your work in helping all of us to get a little more hopeful by having someone out there trying to identify us and share our experiences to others. And I really appreciate you doing that. It's such a boost.
Wonderful. Thank you very much. Thank you, Ken.
Okay.